The rest are bits and pieces of slides that you've seen maybe in several other talks, and I'm supposed to try and talk to you about Linagliptin. Now, all gliptins we have been using for such a long period of time, and I think we all agree that they are a very safe class of molecules. But how does Linagliptin stand out from the rest? Now, whenever we are looking at a drug in terms of an anti-hyperglycemic agent, what are the things that we look for? First of all, it should be able to lower blood glucose in the first place. So that's potency. You're going to have that drug which will work in various different circumstances. That means whether you have bad kidneys, you have bad liver function test, whether it's a young individual, whether it's an older individual, and there will be some durability of action of that drug. It's not that the drug is going to work for say 1 year and then it's not going to work. The drug has to be safe, because that's the first principle that we've been taught: do no harm. You should be able to use it in all kinds of comorbidities and in under all kinds of complications, whether you have neuropathy, nephropathy, retinopathy, whether you've got renal dysfunction, whether you've got liver dysfunction. And the drug should be compatible for use with other anti-hyperglycemic agents, because we know you will ultimately need multiple drugs for the management of glycemia in patients with diabetes. So let us see how Lina is designed to deliver. So the first thing about all of the gliptins in terms of their PK/PD, Lina has the highest DPP-4 inhibition potency as compared to all of the other globally available DPP-4 inhibitors. This is an absolute no-brainer. And in terms of selectivity, we have been taught traditionally that DPP-8 and DPP-9 inhibition might actually lead to certain side effects, particularly the nasopharyngitis and those problems. Here again, Lina scores over the others in terms of the specificity of the DPP-4 inhibition compared to the spillover effect of this molecule in compared to the other DPP-4 inhibitors. So first of all, high potency, high selectivity, and also it has probably one of the lowest free drug concentration amongst all DPP-4 inhibitors. This is particularly useful in patients with liver dysfunction, because the metabolites of DPP-4 inhibitors are either got rid through the kidneys or through the liver, and all of you are aware that Linagliptin has very minimal excretion through the kidneys, and therefore a major portion is metabolized in the liver. So if the levels are low, there's less stress on the liver and therefore safety. So again, Linagliptin, as you can see, of all the gliptin, has very little renal excretion and therefore is safe. Unfortunately, I think because of marketing strategies in India, Lina got labeled as a renal gliptin. That essentially is not the truth about this particular molecule. Now, one of the things you might argue and say, okay, I'm not going to go for dose adjustments, or there's going to be inappropriate dose adjustments, because once you see a patient today, he disappears for the next 3 years. You have no idea what has happened to the liver function, you don't have any idea about the renal function, and therefore all of the dose adjustments that we talk about that should be happening does not happen. And this is registry data from 2 of the biggest countries, which suggest that close to about 50% have a problem in terms of dose adjustment. So they have inappropriately high levels of the drug. Now, one of the things that I already stated was that amongst the major gliptins, if you're looking at, liver function needs to be rechecked at some times, and it cannot be used under certain circumstances. For example, you are aware that probably Vilda is the biggest culprit there, and of the 2 gliptins that can be used, one is Lina and the other is Saxagliptin, and to some extent Teneligliptin. But what is important to remember is none of the gliptins should be used in acute liver disease. So when I'm talking about liver disease, I'm only talking about chronic liver disease. So if you're talking about data in chronic liver disease, Lina has safety data in both child A, child B, as well as child C. So that's the advantage of Linagliptin in comparison to the other gliptins in terms of liver benefit. The renal already we've discussed. Now coming to the first point that I discussed, that it should be a drug which reduces blood glucose. Now, there are no head-to-head trials with any of the gliptins, and everybody quotes study A or study B to say, one gliptin might be reducing A1C up to 2%, 3%, something like that. But this is a meta-analysis or network meta-analysis of 83 RCTs comparing all the DPP-4 inhibitors. And honestly, if you ask me to choose, there is hardly any difference between any of the DPP-4 inhibitors. So a DPP-4 inhibitor, whether it's a Linagliptin, whether it's a Vildagliptin, they're probably all the same in terms of glucose lowering. And we are aware that Asians have higher DPP-4 levels. So we expect that the efficacy of these gliptins are going to be higher in Asians compared to the Western counterparts, and that is also shown in this particular slide. Now, the other thing that I was talking about is durability. Now, you might argue and say that gliptins ultimately are secretagogues, because indirectly it increases the insulin secretion through the incretin effect. There are studies to suggest that this secretagogue effect is persistent even if you have a short duration diabetes, someone who's had diabetes even for more than 5 years, it seems to work similarly. And from the Carolina study, we know that Linagliptin, at least for the period that it was used in the Carolina study, that it worked quite well with as comparable to something like a 2 milligram glimepiride. We all talk about glycemic variability, and this is one study which suggests that if you're using Linagliptin, there is improvement in postprandial excursions and minimal changes in glycemic variability. This is again another study which tries to show that the drug keeps working at least until 2 to 3 years after the start of the molecule. And of course, like you already know, that it works irrespective of what the renal function is. Now, when we are talking about SGLT2 inhibitors, if you are talking about glycemic benefits, the glycemic benefit declines as the renal function goes down, because the major mechanism is glycosuria. So, if the renal function is very bad, you will continue to use an SGLT2 inhibitor for its ancillary benefits, but not for its glucose lowering benefits. Now, what about safety of gliptins? Now, when we are talking about safety, the first point to think of is hypoglycemia. So, this is again from the Carolina study, which shows that there is a significant lower risk of hypoglycemia as compared to glimepiride. That's quite understandable that you are comparing it with the sulfonylurea. Now, what are the kinds of numbers needed to harm? So, if you're looking at overall, if you treat 100 individuals for about 6 years, you reduce 1 hospitalization due to hypoglycemia. So that, because that's what we are more interested in. We are not interested in minor hypoglycemia. Most patients will be able to manage that. So you will have to treat 100 individuals for 6 years to prevent 1 hospitalization compared to glimepiride if you are using Linagliptin. Weight neutrality, that's true for all of the gliptins. And if you look at again the Carolina study, at the end of the period of the study in the Carolina, there was a 1.5 kilogram weight difference between the glimepiride group versus the Linagliptin group. So that at least is reassuring that it does not put on weight, and maybe there is a reduction in weight in terms of 1.5 kilograms. Now, cardiovascular outcomes. Whenever we are talking about the heart with a DPP-4 inhibitor, we will have to talk about heart failure, we will have to talk about cardiovascular outcome, and we will have to talk about QT prolongation when you are talking about DPP-4 inhibitors. So first of all, let us look at heart failure, because if you look at heart failure and DPP-4 inhibitors, the story started with first the EXAMINE trial, the allogliptin, then the SAVOR-TIMI trial, and then came the TCOS. Everybody said TCOS was neutral in terms of heart failure. But if you look at sitagliptin, there is at least 25 different studies on heart failure and sitagliptin with variable results, some suggesting an increase, some suggesting a decrease. So the first bit that I would like you to look at is time to first occurrence of confirmed heart failure. There is no increased risk. Now you might argue and say that if you take people who don't have risk of heart failure and you give the drug, they will not have any increased risk. But remember, Carmelina had 3/4 patients who had bad kidneys. Having bad kidneys is a major risk factor for having heart failures. So individuals who had bad kidneys and individuals who had previous history of hospitalization due to heart failure, you used Linagliptin and still there was no increased risk of heart failure hospitalization, which is far more convincing data than any of the other DPP-4 inhibitors. So if you are looking at the risk factors of heart failure, who has heart failure? Older individuals, those who are on insulin, those who have bad kidneys, those who have increased albumin creatinine excretion rates. So if you're looking at all of those parameters and you're comparing them with people with relatively normal parameters, there is no increased risk of hospitalization with heart failure in the Carmelina study with Linagliptin. So if you're looking at overall the heart failure risk studies, obviously the Savartimi and the examine trial showed risk. The TCOS did not show any risk of heart failure with sitagliptin in the TCOS trial, but there is a catch to it. TCOS excluded everybody with bad kidneys. So we don't actually know if you included people with bad kidneys what would have happened if you use sitagliptin. And of course, VIVID actually had a signal towards increased risk of heart failure, and of course Teneli does not even have any data on that. Now coming to the 3P MACE, because that's kind of become the holy grail of cardiovascular safety of all drugs. If you look at Savartimi neutral, examine neutral, TCOS neutral, Carmelina neutral, Teneli and Vilda does not have data. Remember, unlike the other DPP-4 inhibitors, Linagliptin has got 2 cardiovascular outcome trials, the Carolina as well as the Carmelina, looking at 2 different kinds of population. One with a relatively lower risk of having a CV outcome, and the other, the Carolina, having a much higher risk of having a cardiovascular outcome. Now that's RCT data. What about real world data? So this is from the real world from 2 different countries to show that there is no increased risk of heart failure. Actually, there might be a lowering of risk of heart failure. Don't trust that data. Real world data has its own problems, so don't go by it, but at least you know that there is no signal towards increased risk of heart failure. Coming to QT prolongation, when particularly Teneligliptin came in, we were all worried about QT prolongation with Teneligliptin as well as sitagliptin in supraphysiological doses. So there are now studies to show that with the supratherapeutic doses with Linagliptin, there is no QT prolongation. With sitagliptin, there is prolongation, but that's not clinically relevant at all. With Vildagliptin 100 mg, there is recent data to suggest that there might be some increased risk. Teneli, of course, there is QT prolongation, and that's there on the label. Coming to the renal safety aspect of these drugs. So we've already discussed that Linagliptin is one drug where it's excreted predominantly non-renally, and therefore you do not need any dose adjustment compared to all of the other gliptins that we are using clinically. Now, if you look at the participants in the Carmelina trial that I was talking about, more than 50% of them had established cardiovascular disease, and about 75% of them had established renal disease, and about 1 in 3 had both cardiovascular disease as well as renal disease. So you're looking at a very high risk population in terms of the background risk. And if you look at what we would now call a composite renal outcome, there was no difference in the Carmelina study, essentially telling us that the drug is safe in terms of renal outcomes, and in terms of cardiovascular outcomes we've already discussed. Now if you're looking at time to progression to albuminuria, so these are people who did not have albuminuria, one group getting Linagliptin, the other group not getting it. So you can see there is a delay in the onset of albuminuria and progression in the grades of albuminuria. That means from microalbuminuria to macroalbuminuria. And again, if you're looking at people who already had some grade of albuminuria, either macroalbuminuria or microalbuminuria, what proportion of them had regression of a grade of microalbuminuria or macroalbuminuria? You can see Linagliptin has that. But I would consider all of these as soft indicators of renal outcome. We are now all looking at hard indicators of renal outcome in terms of composite renal outcomes. What about creatinine doubling time? What about 40 to 50% decline in eGFR? What about decline in ESRD? What about decline in renal death? That data was not there with Linagliptin, but at least this level of RCT data is not available with any of the other gliptins. Now, if you now look at both cardiovascular and renal safety across the spectrum, that is 3P MACE, depending on what your renal function is, depending on what happens to your heart failure, hospitalization, what happens to you reaching ESRD or having renal death or eGFR less than 10. So you can see across the spectrum, the drug is safe in terms of cardiovascular outcomes as well as renal outcomes. And like I said already, that you're not having to make any dose adjustments with the linagliptin in renal dysfunction. And with other DPP-4 inhibitors, I told you there is a risk of having higher levels in about 1/3 to 50% of patients, in whom how this has happened we don't know. Is it the excess level of the drug itself, or is it because these were high risk individuals where something else happened, but their mortality increased with the other DPP-4 inhibitors where you did not go for dose adjustments. So if you're looking at renal safety again, Carmelina is the only DPP-4 inhibitor CV outcome trial which has been done specifically to look at renal outcomes. None of the other DPP-4 inhibitors have dedicated RCTs of renal outcome. Now if you're looking at again the age of the individual, because you might be wanting to use the drug in somebody who's elderly, you might be wanting to use it in someone young. So across the spectrum of age, because India is now an aging population, so you can see across the ages and across renal dysfunction, levels of renal function, the drug worked equally well in terms of HbA1c reduction. And if you're looking at the risk of events, cardiovascular or heart failure, irrespective of the age, irrespective of renal function, irrespective of heart failure, the drug is working safely, telling us that it is safe to use the drug even in the elderly population. So therefore, you can use this drug in newly diagnosed, in people having it for a long period of time. You can use it in any combination with any of the other molecules that you're using. You can use it in the elderly, and it is safe drug. It almost reminds me of the Hero Honda ad which tells, fill it, shut it and forget it. You can probably use the drug like that. Now when you're talking about the use of this drug with other molecules, now there are only 2 DPP-4 inhibitors and SGLT2 combinations which have had RCTs. The bigger one is linagliptin with empagliflozin. The other is saxagliptin, which you are not using. The Q10 molecule we are not using in India. This is the Empa-Lina combination is the only US FDA approved product which is a combination of DPP-4 inhibitor and SGLT2 inhibitors. I'm not going to bore you with SGLT2 inhibitors because you'll have plenty of talks on that. Just to recap, that the 2 molecules will actually work well in terms of synergism, in terms of HbA1c and glucose lowering, in terms of safety. It will not offshoot the benefits of the SGLT2 inhibitor, because you want the benefit of the SGLT2 to persist and not use the Saxa with the DAPA in the Saxa-DAPA Q10 combination. And this is, you can see even that combination has prolonged benefit in terms of glucose lowering and will work in all levels. I'm not going to talk about the huge benefits of SGLT2 inhibitors. So if you're looking at guidelines, you're looking at SGLT2 inhibitors in almost every guideline. But remember, one of the things that we have shifted our focus from is glucocentric approach to a morbidity or comorbidity centric approach. In doing so, unfortunately, I have seen some of my super specialist colleagues forgetting glucose management. A GLP-1 is there, a SGLT2 inhibitor is there, the blood glucose control is still not there. So we will need molecules to control blood glucose as well. Let us not forget that glucose control is primary. Your choice of agents is secondary based on your comorbidities. So that we have to remember, and therefore the gliptins will be there. And like I said, this is one molecule which will be safe across the board in all of the circumstances and all of the situations. For example, in an in-hospital situation, a patient has come to you with pneumonia. Either you have the liver function test or the renal function test reports, or you don't have it at that point of time. If you don't have it, Lina is a safe bet. If you have it, the renal function and the liver function test might worsen during the stay of the hospital and you'll have to change your drug. So whatever situation, whether it's in hospital or an OPD setting, this is your drug to go to. Thank you very much.